Thank you very much for the invitation to speak to you today. I think for me, one of the biggest gaps from research into translation would be that nutrition trials are very short, typically in duration, 12, 24 weeks. Rarely do they last a year. And the participants often are less than 50. And so when you're looking at nutrition interventions, it's kind of difficult to really think about the results that only last a few weeks in terms of long term, whereas with pharmaceutical trials, often those studies last for several years. So that's one of the gaps, I think, between it's hard to think about translating things that you've only studied for a few weeks, perhaps, into clinical practice. And I think the other thing in terms of the real world is that physicians who are working with patients and give them a diagnosis of diabetes do so in the context of a very short medical appointment, and they don't really have time to translate or help the patient with lifestyle interventions. When they give a person a diagnosis of diabetes, they might say, you need to take this medicine, and here's a glucose meter. And they don't have time to talk about healthy eating and the role of physical activity. And so I think one of the gaps also is that there are dietitians and diabetes care and education specialists out there that can help patients make an individualized plan to take care of their diabetes, but the physician doesn't make the referral, or they don't have that support person like a dietitian or a diabetes educator in their clinic to actually provide that education. A case study or something that we did in terms of, I started my work at the University of Washington in the endocrinology specialty clinic. And what we know is about 80% of people, 90% of people with diabetes are cared for by primary care providers. So our case study or our work began with myself leading a project in the primary care. So the funding was, we got a little bit of money from our primary care network in the health system that I work for to provide diabetes education right in the primary care clinic. So we created a diabetes education curriculum for people in primary care, so not going to a specialty clinic. So the patient came to the actual clinic where they saw their primary care provider and got education in that clinic setting. And we kept the results of those and evaluated the data. And what we found was that patients, when they received primary diabetes education in the primary care clinic, they had A1C reductions of over 1% from a 6-hour education course. So with the results of that work, we took the results to the organization and said, please fund diabetes educators in primary care. And so we were successful. We've grown the staff from 2 staff members to 7 in the last few years. Well, I would argue that low-carb diets are not, the first part of your question, new and emerging. Low-carbohydrate diets are how we took care of people with diabetes before we had insulin. So, but I think you bring up a very good question in that people have to eat. You know, the most common question that most people have after a diagnosis of diabetes is, what do I eat? Because it's something that we have to do to sustain our lives. When the American Diabetes Association convened a writing group to tackle nutrition therapy to create a consensus report, they tapped different sorts of people to look at to take on this project. And the group started with looking at inclusion criteria. So that kept our task very focused, and we wanted to look specifically at like eating patterns for people with diabetes, because that's one of the most commonly asked questions is what can I eat? So we looked at our inclusion criteria, the numbers of participants, study durations, the types of research studies that we wanted to look at, and we held fast to that. And so that helped our group stay focused on making sure that when we looked at the research and then looked at our findings from the results of our review of the literature, that we kept our goal in mind. So then we were able to then translate those findings into the recommendations that were made for the report. As a past chair of the Academy of Nutrition and Dietetics, Diabetes Care and Education Practice Group, we're 4,000 dietitians in the United States that practice in the diabetes education and nutrition space. And the certification board, which I serve on now, kind of oversees a certification for not only certified diabetes care and education specialists, but we now also oversee the board certification in advanced diabetes management certificate as well. And what those credentials kind of have in common is that if a person is wanting to achieve that, they have to look at the different core curriculum contents for diabetes education. So that person needs to do a deep dive into learning about nutritional aspects of diabetes care, physical activity, behavioral health, medication, chronic complications, and acute complications. As a registered dietitian, I know a lot about the role of nutrition, and because that was my academic preparation. So before I became a certified diabetes care and education specialist, I kind of lived in my nutrition, we call it a silo or my tower. But by studying for the certification exam, it really forced me to kind of get outside of the box and look at all aspects of diabetes care and education, because people with diabetes need to know not just about what to eat, but the role of activity, how their medications work, how glucose monitoring is used in their management. And also we know people with diabetes tend to have a little higher rates of depression than other people without diabetes, the role of behavioral health as well. So having those core topics that you learn a lot about really helps you become a much better clinician. One of the silver linings of the COVID-19 pandemic was the increased use of telemedicine in the delivery of healthcare. Right now, the team of diabetes care and education specialists and dietitians that I supervised at the University of Washington primary care clinic system, they provide 60% of their appointments now via telemedicine. And it is something that helps reduce a lot of burdens of health disparity. For example, sometimes people have a hard time getting into the clinic. So using that medium of telemedicine can really help reduce the time that a patient has to spend to travel to the appointment. As a dietitian and a diabetes educator, I don't have to do a physical exam, so I don't really have to touch the patient, so the medium of telemedicine is just really amazing. Also, I can actually see into the patient's house. I can have the patient go to their cupboard and bring foods that they eat. I can see the glass size that they drink out of. I can see what's in their refrigerator. I can also teach a patient how to take an insulin injection or use a glucose meter or a sensor, glucose sensor, using telemedicine as well. So that's something that has really been fantastic in terms of kind of being able to reach more patients. The other thing, the role of AI, I think that's going to be really interesting. I think it's very important to get evidence-based nutrition. And my worry if a lot of patients don't meet with an educator or a registered dietitian and they just use AI, it might not be as accurate. There's also something about individualizing the treatment plan. If I'm working with a patient one-on-one, either in person, in a group, or via telemedicine, I can get information about that patient and I can individualize their therapy to help them so they can follow it more easily. And that might not, if I'm just looking something up using AI, I don't know. It's going to be hard to individualize things to that person. And the other thing, though, with AI that I know some of my team members are using, many patients will say, can you give me a week's worth of menus, something that I can follow to help me as I'm learning this new way of eating? And that's a very time-consuming aspect. So some of my colleagues, we're starting to use AI to develop, like people can give me their food preferences and then I can plug that in and then be able to create a very individualized plan. But once again, that goes back to using AI in collaboration with the patient.